ASEAN, cộng đồng các quốc gia Đông Nam Á đã chứng kiến sự phát triển và đổi mới từng ngày, từng giờ với những tiến bộ về kinh tế, xã hội, khoa học, kỹ thuật và cả lĩnh vực chăm sóc sức khỏe, đặc biệt là sức khỏe tim mạch. Dù đối mặt với nhiều thách thức cũng như hạn chế về nguồn lực, cộng đồng tim mạch ASEAN đã có những bước tiến vững vàng và sẵn sàng giao thoa với cộng đồng tim mạch thế giới. Đại hội Tim mạch học ASEAN lần thứ 27 được tổ chức tại Hà Nội, Việt Nam từ ngày 2 đến mùng 5 tháng 11 năm 2023 sẽ tập hợp những trí tuệ hàng đầu trong lĩnh vực tim mạch của khu vực và quốc tế, là cơ hội tốt nhất để những nhà tim mạch học ASEAN được chia sẻ, cập nhật kiến thức chuyên môn và hơn nữa, được đắm mình trong dòng chảy giao hòa giữa các nền y tế trong khu vực, giữa những tiến bộ của hiện tại và những thử nghiệm của tương lai, giữa trí tuệ người thầy thuốc và sức mạnh của công nghệ mới. Thành phố vì hòa bình chào đón các bạn với tất cả sự hiếu khách, lịch sử văn hóa đặc sắc, cùng kho tàng ẩm thực độc đáo. Chào mừng đến với Đại hội Tim mạch học ASEAN lần thứ 27 AFCC 2023.
So Professor Kwan, we also welcome Professor Hồ Thương Dũng, Chairman of the Vietnam International Society of Cardiology. Vâng, xin chào các bạn đã đến với cả cái live show ngày hôm nay của chúng ta. Thì chúng tôi xin trân trọng giới thiệu Phó sư Tiến sĩ Hồ Thượng Dũng, Chủ tịch Phân hội Tim mạch can thiệp của Việt Nam. So Kwan, can you, thưa thầy là chúng em đang có một câu hỏi với cả bác sĩ Kwan Lee, thì chúng em xin muốn mời bác sĩ Kwan Lee sẽ tiếp tục cái câu trả lời của mình. So Kwan, you can continue your talk right now.
Okay, yeah. So the FRAIL AF study, which was a pragmatic, randomized, open-label trial that was conducted in the Netherlands, they basically asked the question, is it really true that NOACs are better in frail elderly patients who have never been studied in a clinical trial before? So what they did was they screened about 2,500 elderly patients who were already taking warfarin. And then we see many of these patients in clinical practice, they have been on warfarin for many years because they're old, right? And they have indications for a long time. And of those patients, they had a total of about 1,300 patients that met criteria of frailty, right? And then they randomized them into two groups. Half of the patients continued on their vitamin K warfarin. The other half of the patients was switched to a NOAC. And it's important to add that in this study, they did not specify which NOAC. They let the physicians make the decision whether it was the Bigatran, Rivaroxaban, Apixaban, or even Edoxaban. And then they followed those patients for 6 months. The shocking thing about the study was that in the frail elderly patients who were switched to a NOAC, their bleeding risk was higher than the patients with warfarin by 69%. That is a very disturbing finding. And I think specifically in Asia, it is an even more relevant question for interventional cardiologists. In Asia, our patients are smaller, they are more frail, right? And they're just more elderly patients. So when we do PCI on those patients, because as we become more and more aggressive with our PCI, many more of these patients are now subject to the question of triple therapy, what is the optimal anticoagulation. And so, in interventional cardiology, right now, we are not doing a good job of measuring frailty in our patients, right? We just tend to treat them, we look at them and we just say, oh, you know what, I think there's a more higher bleeding risk, so I'm just gonna, do whatever. I think this is a call to arms for us, especially in Asia, that we should start thinking about our frail elderly patients. And perhaps the strategy, right now the ESC ACC recommendations is for us to use NOAC plus, a P2Y12 monotherapy. But maybe the answer for those who are already on warfarin is to keep them on warfarin. Obviously, this trial does not answer any of the questions that we have as to what is the best regimen, because it was not designed to answer that question. But I think it pushes us to be aware that elderly, frail patients are not the same as others, and we have to be thoughtful. We will have to design trials in the future asking that question in that specific patient who is post-PCI.
Yeah, so actually I think maybe that is there are some gray zone in the recommendation of clinical trial that we could not reflect our daily clinical practice. So now the next question I maybe change to Vietnamese so that I can talk with Professor Hồ Thượng Dũng. Kính thưa phó sư Hồ Thượng Dũng, thì chúng em cũng xin có một câu hỏi rất là đặc biệt cho thầy, đó chính là tim mạch can thiệp thì đang ngày càng phát triển mạnh mẽ tại Việt Nam. Thì thầy cũng là dưới tư cách là chủ tịch của phân hội tim mạch can thiệp của Việt Nam, thì chúng ta thì càng ngày càng can thiệp nhiều bệnh nhân cao tuổi hơn, nhiều bệnh nền, nhiều yếu tố nguy cơ hơn. Vậy thì trên lĩnh vực y học nói chung thì liệu chúng ta có nên đề cao hơn các cái thủ thuật tim mạch của chúng ta hơn là các cái can thiệp với các cái điều trị của chuyên ngành khác hay không ạ? Bởi vì thực tế mà nói thì trong thực hành lâm sàng thì chúng em gặp rất là nhiều tình huống là các bác sĩ của chuyên ngành khác người ta cứ bắt chúng ta là phải xử lý cho xong tim mạch chẳng hạn can thiệp cho bệnh nhân xong rồi họ mới chuyển sang cái tim mạch, cái xử lý cái chuyên ngành của họ. Thì vậy thì ý kiến của thầy về vấn đề này như thế nào ạ? Vì thầy bản thân thầy chúng em cũng biết là một chuyên gia về tim mạch của lão khoa và của người cao tuổi. Vâng. So I'm going to talk to Professor Hồ Thượng Dũng about what he think about the cardiology intervention in the very frail and in very comorbidity patients. And should we treat firstly we should treat the cardiology problem, or we should treat the other comorbidity in those patients?
Okay, thank you. The question from Dr. Minh. You know, Vietnam people by now become elderly population. Yeah, and in clinical practice, we often have the many elderly patients from another specialty, such as the surgeon, such as they always like the cardiovascular doctor determine the risk of a cardiovascular risk for them to do something, maybe to operation prostate. Yeah, I think the first is okay, because for elderly patient, particularly frailty patient, we should have an assessment of the frailty for the elderly patient before we do some technique, some operation. But sometimes it overwhelms, particularly when we use high sensitivity troponin, SS troponin, because in the emergency case, often the high sensitivity troponin high level a little bit. Every doctor from emergency department always asks doctor from cardiovascular department or interventional cardiology to answer infarction or no infarction. Sometimes it's very busy for interventional cardiologist in the night, in every night. So I think it's two sides of the coin. Yeah, to solve the coin. So we must do explanation, increase of high sensitive troponin, not acute MI. It's only myocardial injury, and you must combine with the clinical finding, history finding to determine. So by now, as we know, the guideline from ESC 2023 determine if the HS troponin rise, but not STEMI. It's not necessary to do a primary PCI. I think so. Yeah.
So I would like to have the same question for Professor Quan Ly. So do you think that we should place our cardiology as a higher level than the other specialty? And what is the real clinical practice that you do in the United States?
Yeah, no, I don't think that the cardiovascular issues about
because you know we are the cardiologists, and sometimes we feel that we are more important than the others.
No, definitely not.
Yes.
we should always treat the whole patient.
Yes.
And, you know, there is a tendency to continue to do cardiac procedures in people, even though other things that are going on that are going to affect their life expectancy and quality of life far more than the cardiac issues. I think with the ischemia trial, the courage trial, etc., in stable coronary artery disease, the utility of stenting those patients is really starting to disappear. The problem is, you know, being able to understand the whole patient requires very good overall doctors that then can then rank order each of the different diseases. And frailty in itself is a disease, right? It's a very difficult disease. Patients who are frail don't really tend to become less frail over time, right? If somebody can't walk across the room, should we really be stenting anything? You know, I think we have really to ask ourselves those questions. Perhaps the future is, given the complexity of these issues and our tendency to subspecialize to the point where we cannot see the other pictures, maybe at the end of the day, artificial intelligence, we're going to need artificial intelligence to help us pull the whole story together, you know, in predictive stuff. So, yeah, no, I do not think that the heart is the most important organ. The whole patient is more important. And we always have to ask ourselves, when we do things, what are we achieving? There are only final two things. One, do they live longer? Two, do they feel better? Yeah. And we have so much data now saying that the live longer part is really, in a lot of cases, not true. So then do they feel better? If they don't feel bad, we really shouldn't be doing things.
Yes, as you think, I think we need to treat the patient as a whole humanity, not we treat as a very specific specialty. So I would like to ask Professor Ho Thương Dũng about one question that I have asked Professor Quang Le before, that what is your favorite anti-thrombotic therapy, like NOACs or anti-vitamin K or the antiplatelet therapy in the clinical practice, and especially in the very frail patients?
Okay. I think first we talk about anticoagulation therapy, yeah. And particularly after the study AF, frail AF. Yeah. Antithrombotic therapy, so far we believe NOAC or DOAC is better than VKA, yeah. Because it looks like the effective treatment is equal or maybe higher, but the bleeding risk is less than. And so in my hospital, my hospital is a geriatric hospital. Population of better than 60 is very common. 70 octogenarian or nanogenarian is very common. And by now we give the anticoagulant treatment for the elderly patient. By now, to prevent stroke for AF, 60-70% in NOAC, and 20-30% in continue to VKA, because some reason, maybe economic reason or some, and the patient, the treatment still have effective. And we, according to guideline, we try to make our doctor to change from NOAC continue to vitamin K antagonist to NOAC. But after AF fail, I think it's okay. It's okay because no reason to change. And if you change, maybe more bleeding risk. I understand. And you talk about this trial yesterday, very, very clear. So I think we continue for the treatment, anticoagulant treatment in our hospital, 70% NOAC and 30% vitamin K antagonist. This is the first anticoagulant therapy. And the second point, antiplatelet therapy. As we know, potential antiplatelet therapy includes ticagrelor and prasugrel. Prasugrel, I think, not good for the elderly, but ticagrelor is okay. And the non-potential antiplatelet therapy is clopidogrel. And so, if the patient no acute, it's been chronic coronary syndrome when the patient were stenting, yes, the most of case of course clopidogrel. In the acute setting, such as acute MI, STEMI, non-STEMI, if the patient elderly, very elderly, maybe octogenarian, nonagenarian, octogenarian, if no history have bleeding complication, some bleeding history, we try ticagrelor. If they have the history for maybe gastric bleeding or some more or stroke or hemorrhage, we use clopidogrel.
So in the clinical practice, do you really use the very new P2Y12 like prasugrel or ticagrelor in the elderly patient who have a very complex PCI?
In our hospital, no, by now, no prasugrel.
No?
Only have a ticagrelor.
No prasugrel. Prasugrel is contraindicated. Not prasugrel. Prasugrel is contraindicated in elderly patients. Mainly ticagrelor if we are going to do it.
Ticagrelor.
I think the question for Asian patients is 90 milligrams twice a day the correct dose. You know, in Asian patients very specifically, there was a very good review article last week in JACC Asia from the groups in Taiwan that specifically studied the question of what is the correct dose of NOACs in Asian patients. And in Asian countries, the recommended dose is not the same as in Western countries. And even then, many Asian doctors, they don't exactly follow the guidelines and they tend to underdose even when the higher dosing is appropriate because of the fear of bleeding in Asian patients, which actually might be real, right? It might be based off clinical experience. So I think the question in the future that will need to be answered, we will need to do trials in Asian patients to ask what is the right dose, especially in combination with P2Y12s.
So, Professor Kwan, you mentioned about the de-escalation and short-term DIPT in your talk previously. So, what is your favorite in using short-term DIPT or de-escalation in your clinical practice? And can you tell us how you do that? Do you have some score, or do you have some clinical criteria that you may let the patient to de-escalate or to use a short-term DIPT?
Yeah, I think the literature from Korea especially is very, very interesting in unguided de-escalation, right? Where you just use the aggressive P2Y12s only for the first month. And then you either drop the dose, if you're using prasugrel.
You mean the TPAS?
Yeah, 10 to 5, or you switch from the aggressive to clopidogrel. In the past, there was all these questions about whether we should be guiding this with platelet function testing or genetics. I think that question is out of the door right now. We no longer do that, even though in Asia, the incidence of clopidogrel resistance is supposed to be very high. So nowadays, I'm more and more de-escalating in patients in whom complex PCI was not performed. Even though in the trials, they didn't care. They still de-escalated even in complex PCI, right? So in a patient who hasn't bled, you know, with complex PCI, I'm still not de-escalating them as aggressively. The question is, how do you define complex PCI? That is a difficult question. I think any two-stent stenting technique, you know, bifurcation technique is definitely complex. Any vein graft PCI is complex. Any long lesion is complex. Any, small vessel is complex. And then lots of overlapping stents is complex. So unfortunately, I don't think the DAP score and some of the scores that we use fully capture all those patients. So even though some people like to use the scores, I try still to stay away from the scores because there are many things that we see as interventional cardiologists that don't capture this higher thrombotic risk question, right? Sometimes when we do a lot of IVUS, we see a lot of malapposition. Those patients, we shouldn't be.
So you favor the de-escalation rather than the short-term DAPT, right?
Yeah. I favor de-escalation over shorter term. I think the long-term correct question is probably clopidogrel long-term, not aspirin long-term. I suspect that that's going to be true. So yes, I favor de-escalation over short-term.
So actually, we think that one of the most challenging patients that we see in the clinical practice is that those with a very high bleeding risk, but also with a high thrombus or very complex PCI, right? So what do you think about this problem, Professor Ho Tung?
I think the DAPT, dual antiplatelet therapy, we have two ways to step down. The first will shorten of the duration of DAPT, and the second will reduce the escalation. In my personal opinion, if the patient with a high bleeding risk and no high thrombotic risk, no high ischemic risk, we can short-term DAPT. Maybe short-term from DAPT to aspirin. By now, we favor B2 Y12 inhibitors such as the clopidogrel or ticagrelor. And if the patient high bleeding risk in combination with middle or high ischemic risk, we try to use the escalation. The escalation is mean maybe from ticagrelor with the aspirin, we change to clopidogrel with aspirin, or maybe by now some authors suggest ticagrelor 90 mg twice a day with aspirin, maybe ticagrelor 16 mg twice a day with aspirin. It's the escalation because they still have the high ischemic risk.
So you also favor the escalation strategy, right?
If the patient have a high bleeding risk in combination with high ischemic risk.
Okay.
Yeah.
So because our time is limited, so that the last question I would like to ask both of you that what do you think? What is the future of the anticoagulant or antiplatelet therapy? Should our doctor use more or less those medication in the future, or we may have some device like some stent that we have no DAPT, no need to use DAPT, or we use a left appendix closure, and then the patient no need to use anticoagulation.
I think the technology for left atrial appendage closure is getting better and better. The primary benefit of left atrial appendage closure is not really reduction in stroke, but reduction in bleeding. I think in the elderly patients, especially who are on NOACs, the ultimate de-escalation is to take them off the NOAC. Left atrial appendage occlusion allows us to do this. However, the procedure is still too expensive. But within 5 or 10 years, our techniques will get better, the devices will get cheaper. And so that is going to give us a very nice option for the future with regards to be able to come off NOACs and then just stay on the thing. I think many people also forget that the current recommendations for long-term anticoagulation, antithrombotic in patients who meet criteria for lifelong NOAC and aspirin or P2Y12 is to actually discontinue all antiplatelets and just be on the NOAC. After you cross a certain line. In the patients who are not super high thrombotic list, the further and further you go out, I think that is a very important part. And also the use of PPIs. A lot of people forget about the use of prophylactic GI bleeding agents in these patients. they just concentrate on the aspirin and then they forget that maybe I should also be prescribing omeprazole or pantoprazole in this patient for the long run.
So what do you think, Professor
Okay,
Hồ Thượng Dũng?
so I think the bleeding and the thrombosis is always two sides of a coin, always exist together. So in the near future, I think maybe we have more the new device. It's better for prevent the thrombotic event and reduce the bleeding risk, such as the first we by now stand up for coronary. Do you know it's thin strut, and they have the data rule for diabetes only 1 month, and after that we can de-escalation. Yeah. So maybe in for prevent stroke in the AF, we have some technique. Maybe we can radio ablation for to treat the AF become standard knot. Yeah. Or maybe we use left atrial appendage occlusion. And do you remember in stented in BCI? By now, they have a favor for DCB, drug-coated balloon, for replay for stent. Nothing leave behind. So they reduce the thrombus risk. I think so.
Yeah, so actually maybe in the future we may have some, I mean the absorb has failed, but maybe we can have some kind of stent that the patient, they don't need to use any DIPT at all. Only the DCB. Actually, the pharmaceutical company may not like this very much, but maybe this is the future of.
In anticoagulant, by now we have a vitamin K antagonist or fatty 10 inhibitor. But now we have the fatty 11 inhibitor. It have a very good characteristic for bleeding risk. Yeah.
Okay, so thank you, Professor Quang Le. Thank you, Professor Hồ Thượng Dũng, for your very impressive sharing today. Vâng, chúng tôi xin kết thúc cái talk show về chủ đề về các thuốc kháng kết hợp tiểu cầu với cả giáo sư Quang Le và Phó sư Hồ Thượng Dũng ngày hôm nay. Và chúng tôi xin nhắc lại một lần nữa là talk show Con đường tim mạch của chúng tôi sẽ được diễn ra liên tục và sẽ được